Good morning, everyone. Today I would like to present about an emerging but innovative screening tool for diabetic retinopathy. As we know, India is infamously known as the diabetic capital of the world, and diabetic retinopathy is the most common microvascular complication we see in patients with diabetes. It's about 1 in 3 persons with diabetes mellitus have diabetic retinopathy. The gold standard approach for screening is always regular dilated fundoscopy examinations, but in rural areas of India, the referral to ophthalmologist and screening is poor. So here I'm using a technique called nail fold capillaroscopy. So what is this? Basically, we are examining the nail fold capillaries by using a device called nail fold capillaroscopy on which microvascular changes are being observed. Its advantages are its ease, non-invasiveness, safety, speed of execution time, and low cost. So we have included all the diabetic mellitus patients between the age of 15 to 75 years, and we have excluded certain patients with essential hypertension, peripheral vascular disorders, and collagen vascular disorders because these may have similar changes on nail fold capillaroscopy. It is a cross-sectional and observational study, and the parameters of our study are capillary density, tortuosity, neoangiogenesis, microhemorrhages, abnormal forms, and avascular areas. We have correlated the findings on fundus along with the capillaroscopic findings, and we have compared them in patients with and without retinopathy. In our study, we have totally examined 250 patients, of which we have equally divided them into the groups of non-diabetic retinopathy and diabetic retinopathy, with 125 patients having no diabetic retinopathy and 66 with non-proliferative and 59 with proliferative diabetic retinopathy. Coming to the results of our study, when we have compared with the duration of diabetes, when the duration of diabetes is about 16 to 20 years, we have seen reduced capillary density and tortuosity of nail fold capillaries in about 100% of patients, that is in both the groups like 16 to 20 years and also greater than 20 years. Whereas microhemorrhages and avascular forms and abnormal forms are seen when the duration is 16 to 20 years in about 91%, and whereas when the duration is greater than 20 years, it is about in 100% of the patients. We have also compared these nail fold capillaroscopic findings with glycemic control. When there is bad glycemic control, that is HbA1c greater than 8, we had seen that reduced capillary density and tortuosity are seen in about 82% of the patients, whereas microhemorrhages and avascular areas in 91.5% patients, neoangiogenesis in 93.3%, and abnormal forms of capillaries in about 100% patients. All of them have statistically significant values. And finally, when there is a comparison in the different groups of diabetic retinopathy, when there is proliferative diabetic retinopathy, it is about 100% in almost all the patients we have seen reduced capillary density and tortuosity, whereas microhemorrhages and avascular areas in about 83.1%, and abnormal forms in 13.6%, and neoangiogenesis in 16.9%. Here, I would like to specify this point. When there is no diabetic retinopathy also, we could see certain findings like reduced capillary density and tortuosity in about 16% of patients. So this is a picture showing the fundus photo, OCT, and also the capillaroscopic findings of a single patient. So the image number C is the tortuosity of the nail fold capillaries. D, we can see microhemorrhages. E is neoangiogenesis, and the last one is drained capillaries, which is an abnormal form. So nail fold capillaroscopy basically visualizes the nail fold capillaries. It is very well documented since years since scleroderma spectrum diseases, whereas its recent use in diabetes mellitus has been documented. And so in different literatures, reduced capillary density, tortuosity, ectasias, neoangiogenesis, hemorrhages, abnormal forms, and avascular zones have been documented. We have correlated them with the presence of diabetic retinopathy, degree of diabetic retinopathy, along with duration and control of diabetes. In our study, as I've mentioned, we had very good incidence, that is about 100% in patients with PDR. And also in patients with no retinopathy also, we had certain parameters. So I would like to conclude saying that these nail fold capillaroscopic changes have a significant association with severity of diabetic retinopathy, duration of diabetes, and glycemic control. It is identified before the appearance of changes on the fundus. It is a cheap and non-invasive screening tool, and it is useful in prognosis. Thank you.
Very nice study. Sir, can I?
Yeah, sure.
Yeah, very nice study. The only thing you need little multicentric trial for this. And what you yourself said, 16% had shown some difference.
Yes.
So have you checked those patients for rheumatoid arthritis, because that comes
Yes,
in
ma'am.
nail bed when
Yes, ma'am, we have.
it is
We have
not
excluded
diabetic
that already.
mellitus? And have you compared your data with angio-OCT?
Ma'am?
OCT angiograph?
No, ma'am. OCT angio we didn't.
You
Only
didn't.
the plain HD OCT only we have done, not with angio OCT.
Thank you.
But isn't it more subjective, the findings?
Yes.
Is there any, quantify the result? Like it goes, like you're just seeing and saying, okay,
Yes,
this is
sir.
the finding.
Hmm.
Is there any table like this is +1, 2+, 3+, or something like that?
No.
Sir.
Sir, Nanda sir.
Hello, sir. How is it better than the other two? The same, continuous same.
So I'm not saying this is
Yes,
comparable with the regular fundoscopy examinations of fundus camera. This is only basically in rural areas where there are not much facilities. The regular physicians, they can just have this instrument and they can try to detect it before and refer to the ophthalmologist. I'm never saying that this is a diagnostic tool for diabetic retinopathy. It is just for the physicians or RMPs, which normally dominate in our rural areas. Even though
So
people
not for ophthalmologist, as you say.
generally for
Basically
the
physician.
community purpose in rural areas we can
Physician.
try. I'm not saying it's a gold standard or it's basically for ophthalmologist.
Practically, you are saying it is for practitioners.
Screening.
Yes, sir.
Anybody,
Screening.
Yes.
endocrinologists
Screening
or medical
tool.
people,
When-
they can pick one if they have a
yes, if they
take a
find,
photograph,
and they can,
find anything, they can refer it to.
exactly.
I think basically this is the job, screening of diabetic retinopathy to prevent the diabetic retinopathy blindness is not only by ophthalmologists,
True.
but diabetologists, physicians, then paramedics.
They
All of us should join hands all together, and I think that is the message you want to give here.
Yes, sir, because
And,
most of them, even though they refer, they don't come, but if they diagnose and if they send it to us, maybe we can treat them better with
I
early
think it is-
intervention.
We always tell them.
Yes,
because
sir.
the people come, very rarely they come to us. and
Yes, sir,
After
true.
our hours they go to the diabetic. But mostly they come.
From
with
the physicians.
From the physician.
Yes,
So we sometimes then when they are having a checkup every 6 months or 3 months to you, you just have a look at the fundus camera, everywhere, smartphone or whatever the device you have.
Their role is very much important
Very
and complementary for all of us. Actually, we should involve them, we should accommodate them, we should promote them,
If you have any doubt, they can send me. Otherwise, we say
because their help is needed definitely
Yes,
in
sir.
the screening
the
purpose.
same capillaries can also be studied on a small portable dermoscope, which is also used by the dermatologist
Okay.
for their scleroderma diseases and all. So that is about 10,000 to 15,000 cost. So they use it regularly for their diseases, so they can also screen it for us and refer it to
but
the
yours cheaper you
ophthalmologist.
told?
Sir?
Your experience is cheaper?
As compared to
insurance?
previous two, that's what, sir.
No, sir, I don't think so.
How much it is?
The machine costs about, the lower versions are 5,000, sir, and the higher versions are about 20,000.
Then, as compared to cost, which is little more as compared to previous two presentations, what are the positive aspects of your screening?
Sir, that's what I want, like the physicians or the RMPs can screen and send to us. That is what I would like to.
Okay.
Thank you
Okay.
very much. Okay, thank you.
Thank you,